Do you think that there's benefit for the young, healthy man to start a Tadalafil daily or Sildenafil daily?
That's an interesting one. I asked that question of, we had a cardiologist talk about this yesterday at one of our conferences. I asked him that question. He was not, he wasn't able to give me an age at which we should start. I would say if you're a healthy 40-year-old, you should consider start doing things to protect your long-term erectile function. Okay. If you're a sexual human being, and not everyone is, but if you're a sexual human being and your intercourse-based relations is important to you, then I think you need to start thinking about your penile health. Okay. We talked about the lifestyle things. But I think that if you were 40 years of age and you were interested in protecting your penis and you said, I'm going to take regular PD5 inhibitors, I would have no problem with that. I think if you said to me, the 25-year-old comes in who's perfectly healthy, my concern about that population is not so much that they're looking to protect their penis, but they're looking for an extra boost. And while there's no physical dependency on PD5 inhibitors, there's most certainly the potential for psychological dependency, right? This concept of, I'm great when I use vitamin. Guy with perfectly normal duplex operates on his vasculature is perfectly normal. And he's on PD5 inhibitors and he is only able to have penetration hardness when he's on the pill. Not because his machinery is not good enough, but because his confidence level is so low without the pill. So I think that's something that I'm just a little bit concerned about in the younger population.
Sometimes I find that the opposite is sometimes true. It allows them to get their confidence back. If they have a lot of anxiety around sex, that it becomes a little easier to have an erection, and then we try to wean them off. And that is sort of a challenge sometimes.
Yeah. So we published a paper. Lawrence Jenkins was the first author on this paper. He was one of my fellows. He's now at Tulane. And we published this a couple of years ago, and we showed that if you are a man with psychogenically needed ED, so normal hormones, normal vasculature, and the strategy you talked about, confidence restoration through PD5 inhibitor use, 90% of those men who are in a relationship are off pills in the long term, that you can restore their confidence. Now, I say in a relationship because if you happen to be single and every 2 months you're starting a new dating or a new situationship, right? I think that that's a new stressor to you. Every new partner is a new adrenaline generator, right? So I think that in the confines of a sustained, loving, comfortable relationship, then people's confidence comes back.
Yeah. I love that you know the word situationship.
Sexual medicine doctor.
Yeah. I want to briefly touch on intracavernosal injections, which are therapies that I think are very underutilized and underknown for men with erectile dysfunction. So let's talk about how they work.
Yeah.
And how many spots today?
Yeah, so that's a bit of a lesson in history, right? So credit one's still alive. I think Ron Virag is a vascular surgeon in Paris, and during an operation on the lower limb, they were injecting medicine to cause vasodilation of the arteries in the leg, and the injection went into the wrong artery, and the patient got an erection. And that was an injection with a drug called papaverine. And then around the same time, a chap named Giles Brindley from the UK was doing this with a drug called phenoxybenzone. And that was 1982. And then by 1985, injection therapy became a big deal in the United States. It's never been, there are FDA approved and non-FDA approved drugs. So it is basically the use of vasodilator drugs that are injected directly into the shaft of the penis, into the meat of the penis, using a diabetic needle, middle of the shaft, nowhere near the head, mosquito bite, Mr. Jones. Okay. And depending on the population that you're looking at, but it has an incredibly high success rate. I mean, if you come in to see us and you're post-prostatectomy and you're start injections within 6 months, 92% then get penetration, hardness erections, I say, men, you'll get an erection we'll be proud of. Okay. And they're incredibly, incredibly potent, right? From a safety standpoint, of course, the only concern will be priapism, really. Okay, so the induction of an erection that a man cannot get rid of. Those 4 hours, call your doctor erections that you see on TV. And the chances of that happening in a well-organized, well-monitored program is very low. In our program, it's 0.2% of men who get a priapism, and it's probably maybe 5 times not getting a prolonged erection. 2 hours, but not getting to 4 hours. But incredibly, incredibly effective. The problem is that there's a 50% dropout rate over 5 years, right? And this is not even in the rehab population. This is in the general ED population. People just get tired of the whole injection process. It's not very spontaneous. Hold on, honey, let me inject. Okay. And so I talk with all of my patients and our trainees about the concept of integratability. That if you're on a drug treatment, on a treatment for ED, whether it's a drug, a vacuum device, even a mental health strategy or an implant, if it's not integratable into your lovemaking, you're never going to stick with it, right? And so the problem for injection therapy, as effective as it is, it's just as difficult to integrate into lovemaking. So take, for example, the 45-year-old recently divorced male, post-prostatectomy, out, wants to start dating again. He's single. Now he's got to bring his injection medicine on a date with him, right? So it's hard to integrate that into lovemaking. We understand that. But I think for temporary confidence restoration, for showing men that their machinery is functional again, I think injection therapy is a fantastic strategy.
Are there errors that men make when starting therapy?
Yeah, I mean, the classic errors would be, and errors in quotations would be just bad injection technique. Even though we train them how to do it in the office, we use 2 injection visits. Many urologists use 1. We use 2. They're nervous at home and they just don't inject at the right angle, the wrong depth. We have men who are, it's needle in, plunger down, needle out, pressure between 2 fingers, Mr. Jones, for 3 minutes, right? But as the plunger is going down, they're pulling the needle out because they got to get the needle out as quickly as possible. The major concerns we have are men who change the dose themselves, right? Okay, so we send patients home after the second injection visit. We say, you're on X number of units of Trimix or Bimix or Papaverine. We don't use a lot of Edex or Caberject, which are the 2 FDA-approved drugs. And they just, I'm not getting an erection that I'm happy with, and they self-adjust their dose. And they'll come into me all the time, and they'll say, well, I just went from 4 to 5 units. And I'll say, well, Mr. Jones, that was a 25% increase in your dose. So if we look at our patients who don't do what they're told to do, they have a 10-fold increase in their quietness rate.
Yeah.
Okay. So that's an issue. Then we have men who want to inject twice within the same day or twice within 8 hours of each other, which is, generally speaking, no. But if you're well trained and well monitored, it's really easy to do. It's actually quite difficult not to do it properly.
Yeah. I think the other thing about the medications is some of the medications require refrigeration.
Yeah.
And that can be a real challenge.
Yeah. So medications that contain prostaglandin E1, because it is inherently unstable and loses its potency, its kind of activity over a 4+ month period, that needs to be refrigerated for sure. Now that's over time. So if you've got a bottle of Trimix, you want to refrigerate that. You don't want to be carrying your bottle around wherever you're going.
Yeah.
But if you're going away for a romantic weekend and you're on injection therapy, just pre-fill 2 injection syringes.
Yeah.
And you don't have to be crazy about refrigerating them. Your prostaglandin doesn't deactivate over the weekend. It's the accumulated exposure over time, weeks or months, to room temperature that causes a problem. But for those patients who struggle with refrigeration, then we just use Bimix, Papaverine, and Phentolamine without prostaglandin.
So I know you have a lot of expertise from working at Memorial Sloan Kettering on particularly taking care of men after prostate cancer who have erectile dysfunction. So what is the true rate in modern day of erectile dysfunction after a radical prostatectomy?
Yeah. So I think that's an excellent question. And it's difficult to answer it with a number because, as you know very well, there are many confounders, right? So patient age is a factor. The younger the patient age, the better men preserve their function. There is based on erectile function. Okay. Sometimes age is a surrogate for that, but sometimes the younger men have got bad erections due to diabetes, for example. So the better your erectile function going into surgery, going into radiation, the better your recovery or preservation. At the time of surgery, there is nerve sparing, and that's very, very important. So for somebody who comes in to see me pre-op, I always say, when you speak to your surgeon the morning of surgery in the pre-op area, don't say, Dr. Easton, chair of the urology at Memorial Sloan Kettering Cancer Center, Dr. Easton, don't forget, do your best with my nerves. The better the nerve sparing, the better the recovery. And then from a radiation standpoint, the higher the radiation dose, the greater the problem. And then probably the most penis-threatening thing that you can do to a human being will be take their testosterone away from them. And as important as androgen deprivation therapy, ADT, those drugs that cause testosterone to go to zero, as important as they are in the radiation patient and in the advanced prostate cancer and metastatic prostate cancer patient, they are really, really bad for erectile tissue. So if you think of your penis like your biceps, Mr. Jones, you put your hand around your penis, most of what's inside your hand is a muscle. If you put your arm in a plastic cast for a year, that's really what Lupon's going to do. Those drugs, Lupon, abiraterone, etc. That's what those drugs do to your penis. You need some testosterone for erectile tissue health. It's actually probably not a huge amount of testosterone, but you need some. When you have none, reflexly, in time, that muscle undergoes collagen deposition. Now, that's not in 3 or 4 months, but those patients who are on hormone therapy for a year and a half, 2 years, which is increasing now because of the stage migration of prostate cancer, those patients have really huge problems. So if you take men in our practice who have been on long-term hormone therapy, almost none of them will ever be PD5 inhibitor responders. They will need at least the injection. So getting back to your question, after prostatectomy, I think it would be very fair to say to a patient, in general terms, you will have a 50 to 60% chance of getting back function with or without a PD5 inhibitor 2 years after your prostatectomy. And I think those figures are approximately the same for patients who have radiation therapy. Okay. Now, if you have radiation therapy with long-term ADT, if you have non-nerve sparing surgery, then these figures change dramatically. But I think to the average patient, 50 to 60% PD5 inhibitor response rate 2 years is a very honest and reasonable estimate preoperatively.
And it's pretty much equivalent between surgery and radiation.
Yeah, I get these patients all the time. What should I do? And I always say, I'm not a cancer doctor. I'm not going to tell you what to do. What I say to them is as follows. 3 years after each intervention, the ED rates are approximately the same, provided you've good nerve-sparing surgery and you've radiation therapy as monotherapy. When you start doing non-nerve sparing surgery, when you start doing ADT of different durations, then it just becomes impossible to estimate for those patients.
Yes.
So I say to the patients, speak to your surgeon about nerve sparing, based on your PSA, your MRI, etc. What are the chances of good nerve sparing? And I say to the patients, speak to your radiation oncologist and ask about the role of ADT, and especially about the duration of ADT. And I always say the same thing to patients, ask your rad-onc, your radiation oncologist, about the survival benefit of 2 versus 1 year versus 6 months. And you decide then, is that survival benefit important to you? Yeah. If it's 6 months or 6 years, you make that decision. I don't think I have a phrase that I use now in my lectures of obsessive oncocentricity. That cancer doctors are like, PSA for prostate cancer or CEA for colon cancer, etc. And really, we need to empower patients to make better decisions for themselves, right? So I'm a big patient advocacy. This is classic shared decision. The patient should be the one who's making those decisions. We give them the information, and then they decide.
Absolutely. Because quality of life matters.
Yes. We are survivorship physicians, right?
What about more focused therapies? Like there are now emerging focused therapies, high intensity frequency ultrasound, also called HIFU, cryotherapy, those sorts of things.
Yeah.
What have you seen in those patients?
Yeah. So there really are no long-term studies to look at cryotherapy, HIFU, and some of the more modern things like irreversible electroporation and things like that have had as a focus sexual. Okay. I think that if you look at Mark Emberton's data from the UK, that unilobar treatment, so hemigland ablation it will be called, so half of those patients are most probably going to do better from an erectile function standpoint than classic radical prostatectomy or radiation patients. I think, however, when you get to whole gland ablation, then you start getting into rates of ED that are approximately similar. Okay. To prostatectomy. We have a lot of patients at Memorial who want kind of ejaculation-sparing prostate cancer treatments. And so they go for things like HIFU or they go for things like IRE. Okay. They have to be made aware of this. If they're listening to this, you must understand that those treatments are administered very closely to the ejaculatory ducts. And the ejaculatory ducts are millimeters apart from each other. Right? And so, I'm only having hemigland ablation, but if they're treating around the area of the right ejaculatory duct, there's a chance your left ejaculatory duct is going to get injured. So it's not uncommon for those men to come in and at least temporarily for them to have an inability to have ejaculation after those minimally invasive procedures. That leads me to the idea of ejaculatory distress, which is a really interesting concept about men who are distressed post-prostatectomy, for example, at their inability to ejaculate. About a third of our straight men are very bothered. Now, that's 80+% of gay men, right? But about a third of our straight men are bothered by the fact that post-prostatectomy, I'll never ejaculate again. And that's not something that's well appreciated by surgeons.
Yes, and it's not discussed to a great extent prior to any procedure, whether that's surgery or radiation.
Yeah. And by the way, after radiation, if you look at our data, and it's the data that we published, 50% of men at 3 years and 90% of men at 5 years no longer ejaculate. Just the radiation damage to the prostate, the occlusion of the ejaculatory ducts, they just stop ejaculating. So in time, they also stop ejaculating.
Now, I want to clarify ejaculation versus orgasm.
Yeah.
Because what happens to orgasmic function after these therapies?
Yeah. So after prostate, first of all, let's get radiation out of the way because there's really not much literature out there. Okay. So my anecdotal experience in a radiation patients, they tend to have better preservation of orgasm than the prostatectomy population. If you look at prostatectomy patients, while they don't ejaculate, nearly all of them are going to be orgasmic. And this is a classic thing in our practice, as you know, where men just don't understand. That's the difference between ejaculation and orgasm. Ejaculation is the expulsion of semen, and orgasm is the pleasure that's derived from that. Yes, our blood pressure goes up. Yes, our pulse goes up. Yes, there are pelvic muscle for contractions during orgasm, but the pleasure is a cerebral phenomenon. Okay, so men are orgasmic after prostatectomy. Everyone says the same thing. It feels different. Right? And even in the long term, I think you would have to, we talk about the new sex after radical prostatectomy. Part of that new sex is you have to accept that your orgasm is going to be different in some way. However, if you look at orgasmic intensity at 2 years, about 50% of men will say their orgasmic intensity is less. About 40% will say it's about the same. And 10% will say consistent. It's more intense post-prostatectomy. And we've no idea why that is. Right?
You mean it's the pelvic floor?
It has to be something to do with pelvic floor.
Yeah, I mean, do you think it's like in those 10%, their pelvic floor strengthens and doing Kegel exercises to prevent leakage? And
that's never been looked at. That's an interesting idea. We've been very interested in doing urethral pressure profiles and urodynamic parameter in these patients. I don't know the answer to that, but it is not a fluke. It is. I've been in practice 28 years, and over my 28 years, thousands of post-prostatectomy, it is 10% of men who have increased orgasmic intensity. There was a lot of concern that, the semen bolus going through the urethra was important for orgasmic intensity, but the 10% having higher intensity says that can't be the case.
Well, I think it's also mental there, right?
Yeah.
Because it's so ingrained in that component of pleasure, reaching that climax, that feeling that, and when it's reduced or gone, it can feel like less intense.
Yeah, and I think that links to the whole, ejaculatory orgasmic distress that occurs after radical prostatectomy.